All right, hey folks, and welcome to our video on myeloid diseases. Now, the unit called myeloid diseases sort of encompasses just a number of hematological disorders with sort of proliferation in your hematopoiesis, which aren't really classified elsewhere. I'm not sure if it's actually a term of the art, but that's not particularly relevant. So, without further ado, here's our big tree of hematopoiesis. Hopefully, you guys have seen this before. And the little markings here show sort of what diseases correspond to what parts on the tree. So we've got primary myelofibrosis up at the top here in terms of it affects all the stem cells. We've also got aplastic anemia, which is not part of this diagram, but which also affects the top. And then your gray bits there, those are your leukemias. We're not going to talk about them or lymphomas in this video because we've got a later one coming out on those. But they are obviously errors in formation. And then there's multiple myeloma down here, which we will talk about. Polycythemia, rubra vera, essential thrombocytosis, and we'll cover a few other things that are not as easily classified on this chart. All right, so let's dive into it. With basically all of these, what I'm going to do is I'm going to run through what is actually happening, what the actual disease process is, what the signs and symptoms are, what your the important investigations and the treatment. So you do not need to know all of this stuff. For most of something like this, for example, if you were to memorize all of this, I'd say it's definitely it's definitely overkill, but it's useful to understand what they are. And there's a couple things that are more buzzwordy, which I will point out as we go. So, aplastic anemia. This one is almost sort of like the simplest one or the most fundamental one because it's basically there's something wrong with your stem cells at the very top, and so you're not making any type of blood cells, and so you get an anemia, sure. So you get a lack of red blood cells, and you get those symptoms associated with anemia. But that's really only part of the problem. So the anemia is the most visible part of the problem, but it's actually a cytopenia or lack of cells of every type of cell that comes from that whole tree. So your anemia at the top, your thrombocytopenia for your platelets, and your leukocytopenia. If you do an investigation, really that FB thing should say low red blood cells, low platelets, low white blood cells, everything. So it should be a pancytopenia. If you look at a bone marrow biopsy, you'll see like a normal bone marrow, it looks pretty like red, like a big, I don't know, like a chunk of meat or something. When you look at a aplastic anemia bone marrow, it'll have these big, huge holes in it, and that's where there's a bunch of fat cells infilling, where there's no longer proper marrow cells. Now the treatment is based on how you developed it. So if you're getting exposed at work to some sort of toxin that's causing it, and there's a whole list that you don't really need to know. If you're getting exposed to one of those, then you want to remove that from your environment to prevent any further progression. If there's immune-mediated, so there's quite a lot of autoimmune causes for this, and so you put them on immunosuppression, and in all of them you can, if the disease has progressed to a significant amount, you'd consider a bone marrow transplant. Okay. All right, so in terms of the high-yield ones and stuff that's going to come up on your exam, so polycythemia rubra vera is a pretty good one. It's also a good one because the name, like it's right there in the name. So you have too many red cells. In terms of what you're actually likely to see as symptoms and what's likely to come up. So really the big pathognomonic thing is like pruritus which gets worse. So it can be present at baseline, but it gets worse after you take a hot shower or a bath. And associated with that, well, think about it. So you have too many red cells, what's going to show up? Well, first of all, your face is going to get big. Not big, it's going to get nice and red because there's so many red cells there. And on examination, so you won't see it on history and the patient won't mention it. But if you then do an examination, you'll find that their liver is quite big and their spleen is quite big. And that's the case of things basically just backing up. So your spleen is where a lot of your red blood cells hang out or are processed. And a lot of them also pass through your liver. And so they're going to be bigger, basically. So all of the investigative findings are fairly straightforward. How do we treat it? Well, we basically just let them bleed out a little bit, and they lose red cells, and then once they're at a level that we're happy at, then we leave it. And then the other thing that we care about here is that we also care about the risk of thrombotic events, like clotting, as a result of having so many red blood cells kicking around. And so we'll put them on aspirin or something like that in order to prevent that from happening in the first place. Yeah, and they can progress to different types of disorders based on where exactly the issue is. All right, so essential thrombocytosis. I do want to make the note that a lot of the things we're going to talk about here, so we talked about anemia, we're talking about thrombocytosis, we're going to talk about myelofibrosis in a second. A lot of these things can show up as secondary to another disease, so something has gone wrong and then you get, the effect is that you get this. And the distinction with these conditions is that they are, well, essential or primary, whatever you want to call it. The actual problem is this. So it's not that there's some other syndrome which is causing it. This is being caused by some cause which is only really affecting this. So you have too many platelets. What do platelets do? They clot. Therefore, what are you likely to do? Thrombotic events. That's really the biggest one. Spontaneous abortion is big only because they you're not going to get it in most of the other questions. In terms of what you find, shockingly, you get a lot of platelets. If you do a blood film, you get mature megakaryocytes. So those are the cells that make platelets. So they're overexpressed here, and so you're going to see more of them on the blood film. In terms of treatment, so with a lot of these stuff, sometimes we leave it, sometimes we treat it. In this case, we really only treat it if we feel like they are at a risk of clotting, because platelets by themselves, thrombocytosis is not really that big of an issue on its own. Yeah. Okay, and again, same thing. So you can get myelofibrosis secondary to something, but you can also get it primarily, so it's its own thing. So basically, there's cells in your bone that are responsible for creating some scar tissue and or fibrosis. And in this sort of setting or this disease process, they're overstimulated and they make too much scar tissue and they scar up the whole thing. And obviously, that's quite bad for you. So yeah. In terms of what you get, so you get hepatosplenomegaly, which we've already talked about. Your investigative findings are all pretty straightforward. So you get lots of low stuff because of the disease inhibiting your production. One of the really big things, so make sure you remember it, teardrop cells. So if you look there at the diagram, and there's some cuties over here, there's one over here, sort of in its own little group, which is a really nice teardrop cell. And so basically all that means is that the cells are having to squeeze out of this really fibrotic and stiff bone marrow when they are produced. And so that causes the teardrop appearance. Now, one thing that I have failed to comment on so far, which is important, is the JAK2 mutation. So you saw it pop up in PRV, ET, and now primary myelofibrosis. And it's basically just a genetic mutation which affects what we call Janus kinases, which you probably remember a little bit from your. Oh, you might not. You won't have done leukemia anymore yet. The point is, they're important in implemented in a lot of cancers, or implicated rather in a bunch of cancers, and here they're also relevant. So you see them pop up in previous ones. The amount they're positive varies quite a bit. So if you have PRV, you probably have a positive JAK2 mutation. That's not to say that if you have the JAK2 mutation, you'll develop PRV. So be mindful that it doesn't necessarily go both ways. In terms of other things for your myelofibrosis, so you get just air basically. So you put in your little bone marrow biopsy probe. Usually there's a whole bunch of gunk there you can get out. In this case, it's all fibrotic. There's no actual stuff there. And so you just get air basically, or dry, or just something that has no moisture in it. Okay. Yeah. Okay. So in terms of multiple myeloma, this one is basically just a case of you have those plasma cells that are produced all the way at the end of that B lymphocyte sort of pathway. It has some really sort of cardinal symptoms. So hypercalcemia, renal failure, anemia, and bony lesions. They form that little convenient acronym there. There's also some interesting investigation. So on bone marrow biopsy, it almost looks like a joke, like it's just all plasma cells. And so you can see, well, myeloma. In terms of blood film, you get what we call rouleau bodies. And so those are basically just a big stack of red blood cells that are all joined together because they've all been squished. Yep. I've never seen a question relating to those Bence-Jones proteins from the urine test, but I guess they're good to know. In terms of treatment, so we have corticosteroids, which are a favorite older sort of therapy. Chemotherapy, because it is sort of ultimately a neoplasm of some kind. And we use these things as a combination therapy. So we don't use them in isolation, we use them together. Okay. Now, myelodysplastic syndromes, it's sort of a weird one. It's not one disease. It's I can't speak today, sorry. It's a collection of diseases. So there's a bunch of different diseases. They're all vaguely related because they are basically problems with stem cells. But the actual specifics of the disease are going to affect what symptoms you get and what treatment you use. So really all you need to know is that they are related to stem cell dysfunction broadly, and that you get either hypercellular or dysplastic appearance on your little bone marrow biopsy. So it's almost the opposite of your acellular anemia bone marrow, which would have been acellular to a degree. And then your FBE, you'll get cytopenia. So depending on where the problem is, maybe everything, maybe something. But yeah, that pretty much sums up a little bit on myeloid diseases. If there's anything else you'd like to ask, feel free to message us. But yeah, hopefully that's a good little overview, you guys. Thanks and happy watching.